a way to treat a problem that my dad had. He had a compression fracture. He's tough as nails. He was in so much pain, he was taking pain medicines and hallucinating. And finally, my brother and I drove up to LA. First, we thought my mom was crazy, but then we saw my dad and he's like, oh, he's hallucinating for real. We drove him down to San Diego. He had a vertebral augmentation. That night is better. So I'm going to talk about a strategy where you can do a very good vertebral augmentation just by going on one side. You traditionally go in bilaterally, but if you go on one side, guess what? It's half the amount of work. It's twice as much work going bilaterally. So I'll show you that. So let me just start off by presenting a case. So here's a typical case. 65-year-old, non-small, diabetic, has 8 fibers on Coumadin. She has a slip and fall injury lens on her butt, and she's got this back pain. So we're waiting for her to get better, waiting. After about a month, you can tell the patients that aren't going to get better on their own. 2/3 get better on their own, the other third, they just languish. So around 7 weeks, we just decide, okay, it's not going to get better on its own, we're going to do a vertebral augmentation to treat that L1 vertebral compression fracture. It's not a bad one. And utilizing a uniperpendicular approach, you can get good cement fill, you can get around to the middle, and not have one of those unilateral approaches where all the cement is on one half of the vertebral body. But she's miserable, and she's kind of got this diagnosis of failure to thrive. She's older, she's 83. She's got a grade 2 spondy, chronic low back pain, stenosis, neurogenic claudication. She's had that for a while, but for some reason she's just deteriorated. Get some x-rays, and I think there's a compression fracture. You get an MRI, it's obvious. So there's a T6 and T7 vertebral compression fracture. And luckily, this is a procedure that has a very high success rate and patient satisfaction rate. So same thing. And this up here, it's a little bit trickier than down at L3. But again, a uniperpendicular approach, going all the way around and getting a cement fill. She's doing great. Thank God. So these are the types of cases that we all show. And I would say 90% or more of our patients that have this problem, we treat and we feel like we're the greatest surgeon in the whole wide world. So even, I would say vertebral augmentation is probably the best surgery that we do in terms of success rate and improvement in patient pain and function. Do you guys agree with that? Any disagreement, people? So with that, what I would like to do is demonstrate the two technologies that kind of allow me to do this in the manner that I was talking about. First is the product called Osseon. So it's really simple. If you want to get to a position that's not in line with your approach trajectory, you need a device that will turn, curve, or go in a direction that's off plane. And if you ask somebody outside of spine, they're just like, you mean like a steerable something? In spine, we're like, I have no idea what you're talking about. You can't do that. You have to go from the other side. But that device, that seemingly simple device makes such a huge difference because now I can direct how the needle passes as it goes from left to right, for example. Same thing with utilizing a balloon. I tend to like using the balloon in part because I was trained with balloons, and that's what I'm used to. But I've noticed that when you create the balloon, a couple things happen. One, you can deposit the cement in a much more controlled way. And it just seems like when there is a leakage, I can control it. When I'm doing just a non-cavity vertebral augmentation, if I see some cement going out some aberrant location, it just keeps on wanting to go out that location. I can't seem to change it, whereas a balloon allows me to control that a little bit better. So I'll demonstrate those two things, and you guys can just come up afterwards. So now I can do a couple of things. I can turn this, let's say I want to direct the cement more north, or I want to direct the cement more south. Both that. Now, depending on where I am on the AP, I may not want to hit it more on the lateral. But as long as I know it's going across the middle, double tap, and not going out the front, I'm going to just keep hitting this forward. So So that one little thing, just means, I'm a cheater, I know. It's like, I'm not really a spine surgeon, I slept at a Holiday Inn Express. Because you're looking at that going, what? That's Dr. Kim, like, I could do that. Because look how much easier that is. Double tap. So now I already know. I'm feeling really good right now. Way in the front, going all the way across the front. So if I had to do it with the uniplanar, I probably would have gone up and down at least twice.